I think the next changes will be all fairly small incremental changes. So I think we will begin to learn the sociology, as it were, of why some people can't or won't take treatment, and improve treatments so that they can. So some of it will be side effects, and we can reduce side effects. Secondly, I think in the developing world, we're making great strides in providing care to a wider range of people. I think we need to actually think quite carefully how we manage those people. Is it possible to have them coming to a hospital, or would it be better for a lot more peer groups to be providing treatment and referring only those people who are difficult into some sort of central mechanism? There's a small chance, I think, that cure might be available in the future. I think the major problem I have is that the cure, all the things that are being done for cure at the moment are unbelievably expensive and are really not applicable to the third world. I'm a bit more hopeful about vaccines than I ever was, not in the next 5 years, but I think in the next 5 to 10 years, we are beginning to understand the correlates of protection. I'm a bit more hopeful than that than I was.
So HIV treatment is now highly effective. I think for anyone who takes their treatment properly or is able to take their treatment properly, you should be looking at 100% success rates. There will always be people who fail. We need to make sure in the future that the chances of failure is as small as possible. And that's not only about drugs, it's also about choosing the correct drugs, it's about the side effects of those drugs, and also about supporting individuals with HIV. We need to make sure that drugs become available for all, that their monitoring is available for all, and that we are able to have all the information necessary to make the correct choice. While we're waiting for that dream to happen, however, we have to really use the resources available to us. So the future is looking rosy. What we need to make sure is those patients are able to benefit from any advances in the future. And they are going to benefit from those advances from being there, being well, which means suppressing their virus fully by making the best choice of agents for them.
So in developing countries, resource-poor countries, I think that this will be a big push. And the interesting thing, and where RDI might come into this, is that it can't all be managed by doctors. It can't all be managed by nurses. But people can be trained about how to give the drug, the side effects, and how to determine failure. Then they can go to the RDI system to decide what can be given next. So RDI fits in very well for this sort of global way of managing patients.
In the future, I think that in low-income countries, treatment will probably become more individualized. But that's because there are large efforts underway at the moment to develop point-of-care diagnostics. So, for example, easier to use viral load and CD4 tests, right where the patient is and where the patient really needs that test. And really then the HIV TREPS model is an ideal partner for that individualization to then make a prediction of the actual drug combinations to which the patient would then benefit.
A key to the success of HIV TREPS is that the data we use to develop the models comes from as wide a range of settings as possible. And so we're always on the lookout for new centres, new hospitals from different countries that are able to share their data with us. And so I would really appeal to anybody watching this who's involved in HIV treatment. If you can help us by providing data from your hospital, it will make the models more accurate and particularly more accurate and more useful for patients from your setting.
I'd like to hope that HIV treatment at Chelsea Westminster remains one of the best in the world and will continue to do so. That's a mixture, I think, of the commitment of the staff that we have here and a health service which is free at the point of access, and a wide variety of other researchers who we interact with, including our RDI, who have, a mindset that wants to improve care continuously. So I think we have a healthy, positive future.
So I think here at the Chelsea and Westminster, it's always a time of change. I think that we are a large centre. We're lucky enough to have very dedicated physicians and nurses here. We will continue to be a major player. I think increasingly, though, there's a realization that the knowledge that we have here has to be translated outside of this centre, outside of this country, and into a resource-poor area. I think what we need to look at the Chelsea and Westminster, and indeed we're doing so, is partnerships. And it's about partnering. So, you know, I myself, I've got partnerships, big partnerships in Uganda, in Myanmar, in Vietnam. Others have different partnerships. And so it's all about that partnership. And RDI is one of those partnerships that with us and with the other people involved, hopefully will allow great improvements in the resource-poor world. So it actually matches, or indeed perhaps even does better than what we can achieve in this country.
I've spent over 30 years in HIV and AIDS. I don't seem to be able to escape it. And the greatest thing that's happened is that from talking to patients about dying, especially young people about dying, I now talk to them about having a fulfilled life and to follow their dreams.
I think I've had an absolutely wonderful life. I have to say that I've been one of the luckiest people alive. Not many people can say that they start with a disease that is fatal, and over their career, you turn it into a disease which is entirely manageable and possibly even curable, and an epidemic which may disappear. Wonderful experience.